Hi, everybody. Welcome back. We are going to look at this session. We are going to look at the wound healing process. So, in the olden days, we used to have one set of ointment or maybe two different sets of ointments, and we had a bandage and gauze. And for every type of injury that we sustained, that was applied to our bodies. But as time went by and research was done, we came across the science of wound healing, and we discovered that wound healing is a very complex process and that it's a science in its own right. So within the correct phase of wound healing, if you can identify in which phase the wound is of the healing process, that is very beneficial in determining the wound outcome and also which dressing should be used. Because for every person that has a wound, the overall treatment plan should be optimal and patient-based and patient-centered. So we have three phases of wound healing. We're going to jump right into it. The first one is the inflammatory phase. The second one is the proliferative phase. And then we get the maturation or remodeling phase. So during this training and discussion, it's very important to note these phases can overlap and they are interlaced. So it's not 1, 2, 3. It can overlap, interlaced, but it should follow a pattern in order to be an acute wound or eventually be a chronic wound, but we will discuss that a bit later. So if you look at these sketches that we have on screen for you, you actually see 4 sketches, but please be aware and keep in mind that the first one it's the start of the inflammatory process. So if we talk about hemostasis, it's actually the beginning of the inflammatory process. And then we get the second phase, which is the proliferative phase, and the third phase, which is remodeling or maturation. Both terms are correct. When we spoke about the structure of the skin earlier, we said that the skin is divided in 2 main components, which is the epidermis and the dermis. So please keep in mind and be aware that we said the epidermis is avascular, meaning it doesn't have a blood supply. So if we have a wound and it's bleeding, we must know that this wound is actually penetrating towards the dermis because all our blood vessels are placed and sourced from the dermis. Okay, if you, for instance, get a tattoo, the tattoo ink actually penetrates the dermis. The reasons being that you are bleeding when you get the tattoo, and if it doesn't penetrate the dermis and the ink doesn't go into the dermis, it will desquamate off the corneum, stratum corneum, the dry horny layer, the top part of the epidermis, then your tattoo will just wash off. So just for interest's sake. All right, so back to wound healing. I'm going to start with the introduction here with a definition of a chronic wound. So when a wound gets stuck in the inflammatory phase of healing, it will be classified as a chronic wound. So just to give you an example, if we used it in practice a few years ago, sometimes still today, is when we use gauze dressings, wet to dry gauze dressings. So we wet the gauze with saline, we put it on the wound, we wait till it dries, and we pluck it off. So in order to, what we actually gain by doing that, if the gauze dries out and we pull off the gauze from the wound, we actually let the wound bleed again. So we are putting that wound into the inflammatory phase the whole time because now it's a bleeding wound. The body thinks that this is a new injury and the inflammatory process starts. We'll go into that in detail now. So what we're actually doing in these cases is that we are putting this wound in the inflammation phase of healing, and we are making this a chronic wound in the end. Okay. If we speak about healing by primary and secondary intention, we refer to primary intention is where you have an operation, it's a nice, clean cut surgical wound, and then the doctor aligns the epidermal edges, and they put clips or sutures in, and they heal more rapidly. All right, on the outside. Important to remember here that beneath that nice incision that has healed or epithelialized after 3 days about, underneath the whole wound healing process is still going on. If we look at secondary intention, this is the wounds that we obtain that we can't suture. So what we need to do, if you can maybe picture someone digging a hole in the ground, that represents the wound. We need to fill the hole with ground, and then we need to cover it with a top part or a lid. So this is secondary intention. These wounds follow the path of wound healing, and they will heal by secondary intention. Primary wound healing is where you have an incision line, the edges are aligned neatly, and it's closed by staples or sutures. And then with secondary healing, it follows the normal no surgical intervention route of healing. So if we look at the phases of wound healing, the first phase is the inflammatory phase. So when we look at the inflammatory phase of wound healing, this process starts with a process called hemostasis. Hemo, referring to blood or bleeding, stasis, meaning to stop. We need to stop the bleeding. So when the skin gets broken, bleeding will occur. We need to stop the bleeding in order not to bleed to death or to have severe complications like shock. So when an injury occurs, the following happens. Vasoconstriction occurs to prevent blood loss. So if you have a hose pipe, the hose pipe gets closed to prevent blood loss. The blood platelets are activated, and the endothelial surfaces of the blood vessels become rougher and much more easier to adhere to. So instead of being smooth, they become rougher. And these platelets adhere to these rough interiors and form a platelet plug. So after injury, hemostasis lasts about 30 minutes. And that is the first SOS call to stop the bleeding, to save what blood we have. Then the platelets and the damaged tissue release other factors that initiate the classic clotting cascade within 30 seconds. So the clot will be formed that eventually forms a scab, and this temporarily isolates the wound. So after hemostasis has been achieved, then the inflammatory reaction will take place. So remember, we had vasoconstriction, the blood platelets were activated, the endothelial surfaces became rougher and easier to adhere to, platelets formed a platelet plug, the clotting cascade came into work here within 30 seconds, and a scab a clot was formed that eventually will form a scab. All right, so now we need to go over to the inflammatory reaction. So we spoke about the mast cells that are in the dermis, and these mast cells release histamine. Damaged cells will release various substances. All right, so now during hemostasis, we had vasoconstriction. Now we need vasodilatation and enhanced capillary permeability of the tissue surrounding the injury. Because we have all these cells being released that need to get to the damaged area, we need vasodilatation to increase the blood flow to the injured area. So waste products are also removed due to vasodilatation. The vascular response causes the typical signs of an inflammatory reaction, and this should not be mistaken for infection signs. This is very important to remember. So if you look at inflammatory response system, symptoms, it is erythema and heat, edema, pain or discomfort, and loss or disturbance of function. So if we had an operation and after 3 days, we see that the incision line on the surrounding skin is warm to the touch, erythema and heat, it's red and it's warm to the touch, it is swollen, it's painful, and there's loss of disturbance of function. Can we then say after 3 days that this wound is infected? All right. So remember, the inflammatory phase lasts 3 to 5 days more. So if on day 3, post-injury, post-surgery, these signs are present, it is most likely just inflammatory response systems and not infections. Okay, so during the inflammatory phase, neutrophils are the first leukocytes. Leukocytes are white blood cells. So the neutrophils are the first white blood cells to be attracted to the wound. So they are the emergency responders. They are first on the scene, and within a few hours, they arrive in the X-ray in high numbers to begin up the cleanup process. So the process is done by phagocytosis and by chemically breaking down bacteria and debris via enzyme action. All right, so monocytes migrate to the wound at the same time as the neutrophils, but they arrive only after 24 hours after the wound has occurred. Okay, so the neutrophils, first responders, they are there first and they need to start cleaning up. Okay, so when we say monocytes migrate to the wound and they arrive after 24 hours after the wound has occurred, these monocytes develop into macrophages that continue the clearing started by the neutrophils. Remember, we spoke about the macrophages, and I said you must keep in mind the old game of Pac-Man. So the macrophages are these little Pac-Man that eat, and phagocytosis is the process, the bacteria and debris to clean up this wound bed, this scene of accident that we have. So the macrophages or the Pac-Man are larger than the neutrophils, and they can destroy larger particles. And they are the most important cells in the process, and they are present in all the phases. They play a very important role in producing substances that are crucial for wound healing, including transforming growth factors, fibroblast growth factors, epidermal growth factors, tumor necrotizing factors, prostaglandins, etc. This last part is only for interest sake, all right? That is a very, very complex science going into that. The things that you should focus on, that you should know, is definitely the different cells and the different phases and what the cells do. Okay, so if we look at growth factors are proteins. And while we are speaking about proteins are crucial throughout the whole wound healing process. If a patient has a highly exuding leg ulcer, so there's a lot of exudate draining from the wound, that patient will need protein replacement in order to help that wound to heal. So we will immediately put her on a more protein diet if comorbidities can accept that and can handle that. We will immediately start telling her and educating the patient to take in more proteins daily. Okay, so growth factors are proteins that promote cell proliferation, induce the migration of cells to the wound, and facilitate processes that encourage healing. Okay, so if you think about the growth factors, you'll think about a conductor that's conducting a choir. They're standing there in front with the little sticks that they use with their hands, and they're telling each member of the choir when to start and what to do. So that's the function and the role of the growth factor. Okay, so wound healing cannot proceed to the next phase if the inflammatory phase is not completed. Remember what we said also with a chronic wound. It is a wound that is stuck in the inflammatory phase. So these wounds are not healing. We need to do something that they can go on to the proliferative phase and eventually to remodeling in order to heal. Okay, so when we spoke about the inflammatory phase, remember we said the phases can overlap. So our second phase of wound healing is our proliferative phase. Pro-life, for life. This means that our injury has taken place already, our bleeding has been stopped, our inflammation or inflammatory action has taken place, and our wound has been cleared of debris, our cells have been settled, everyone has been told what to do. So then the proliferative phase lasts about 3 to 21 days post-injury. And this consists of 3 processes, namely granulation, contraction, and epithelialization. Right, so if we look at the first part of the proliferative phase, if we speak about granulation, during granulation, there is a process that occurs, and we call that process angioneogenesis. Angio referring to vascular, neo to new, genesis to make or create. So this means making or creating a new vascular system. So all our small capillaries or blood vessels that has been cut off during this injury need to be re-established because a wound needs the blood supply to heal. So this refers to the formation of new capillaries in the surrounding tissue 36 hours after the wound has occurred. Okay. Growth factors attract fibroblasts. Remember, the growth factors are the conductors. Fibroblast, blast cell making something. So a fibroblast makes collagen. Okay, so the growth factors attract the fibroblasts to the wound area and stimulate them to proliferate, and they begin producing collagen within 6 days of occurrence of the wound. They also synthesize ground substance that with the collagen forms the framework of the new connective tissue that gradually fills up the wound. Fibroblasts are therefore responsible for the reconstruction of connective tissue that will eventually form our scar tissue. The macrophages, or the Pac-Man, support the collagen formation by stimulating the capillary endothelial cells to angiomeogenesis, which leads to the growth of a network on the wound surface. Why? Because we need blood supply if we had a wound or damaged, broken, open skin that resulted in a wound. Nutrients are needed to synthesize quality collagen. Okay, the capillaries that is now form loops or buds at a rate of 0.5 millimeters a day on the wound surface. So the collagen synthesis and the endothelial budding takes place concurrently. So the endothelial budding that we are speaking about, if you look at a healthy wound, if we speak about healthy tissue in a wound, we talk about granulation tissue. So granulation tissue refers to a beefy red, it's very friable tissue, but it's not infected, remember? If we have tissue that's bleeding very easily when we clean it, and it's not granulation tissue, we will think it is infected. Okay, but granulation tissue is a very frail tissue that has a bright red, uneven granular appearance. And the granular appearance is due to the endothelial budding. And this budding is the new capillaries that's forming to supply blood to the wound bed. And that tissue is called granulation tissue. Okay, so important, like I said, we must be very, very careful not to swab it with a gauze until it bleeds, because this will cause it to regress and once again get it stuck in the inflammatory phase. Our wound healing won't continue and we will sit with a chronic wound. Right. So our second phase that we spoke about during the proliferative phase now is that of contraction. Okay, so we spoke about the fibroblasts that produce the collagen. Okay, so some of these fibroblast cells change into myofibroblasts after the wound has filled with granulation tissue. All right, so now the hole that was dug due to injury has filled up with granulation tissue. And now the fibroblasts change into myofibroblasts. And they contain a protein that is similar to smooth muscle. When they contract, they draw the wound edges closer to each other, and the scar tissue shrinks and the wound surface size decreases. So this accelerates the healing process, and less granulation tissue is needed to fill the wound cavity. So as this hole gets filled up with granulation tissue, the myofibroblast contracts the edges to make the area smaller so that the wound healing can occur quicker. Then the third part of the proliferative phase of healing is epithelialization. If we look at epithelialization, it refers to the integrity of the epidermis over the wound is restored in the end stage of wound healing. So now the epidermis was broken. Remember, we said it's epithelial cells. The epidermis consists of epithelial cells. So now the epidermis must close up once again. So these epithelial cells move from the outside of the wound area, and they migrate from the outside, from the side, towards the middle. And this is called migration. And when they meet in the middle, it's a contact inhibition and they stop. So when they meet, it's closed and they stop. So they migrate over the wound bed for 2 to 3 times their length, while the space behind them is filled by proliferation. Okay. If a scab forms, the epithelial cells will dig under the scab and the healing process will definitely be delayed. Okay. So important to remember, migration and proliferation of new epidermal cells. That is regeneration from the basal layer of the wound bed, meaning that the skin regenerates itself from the inside out, from the basal layer outside to the corneum. So then we can ask ourselves, when can a patient shower after an operation? So this final process of epithelialization should occur 24 to 48 hours after post-operative, after the wounds have been sutured or clipped. So on day 3, we will usually open the dressing and we will make sure that the wound has epithelialized, and then the patient can shower. It is also during this time that on day 3, if you open the wound and you see that there's a delay in epithelialization, that you should start taking extra special care and make sure that this wound, this incision line, that the lines are edged and that pink, light pink scar tissue that has started to close it already is there. If it's not there and there's areas that's highly exuding still, it might be inflammation still, but you should keep an eye on that wound very closely to make sure that it is going the right way that you want it. Use the correct products to maybe stop the exudate or not stop it, absorb it, to keep the wound bed moist. We are looking at moist wound bed healing or moist wound healing. The cells that we spoke about during these processes so far, they don't like to wet because they drown. They don't like to dry because then they can't move. So we need just enough moisture for them to fulfill their task. Okay. So epithelialization is a delicate process and it can be influenced by many factors, including desiccation, drying out, cooling of the wound, poor nutrition, poor circulation of the wound, mechanical disturbance of the process, and the use of cytostatic drugs to clean or treat the wound. All right, so new epithelial cells take approximately 2 weeks to differentiate and to develop through all the cell layers to the full epidermis. Remember, from the inside out. Then the last phase of our wound healing, we speak about the maturation or the remodeling phase. And this refers to when re-epithelialization is complete. The wound still needs to mature before we can say that this is completely healed. So the scar tissue is remodeled to improve the tensile strength of the wound. This means that the scar tissue gets stronger and the wound won't just tear open. The scar will become mature and it will actually close that area of the skin. So the tensile strength of newly formed granulation tissue increases by about 10% monthly, with a maximum of 70% of the original in incision wounds. Okay, this refers to when we had an operation and now doctor closed the operation with clips or sutures. Every month, that tensile strength grows or gains 10%. So month 1, 10%, month 2, 20%, month 3, 30%, up to a maximum of 70% of the original in incision wounds. So if we go and we do multiple operations on the same incision line, it won't heal, because now we will only regain a maximum of 70% of the one we started with, meaning that that will break down and the wound will dehisce. That's the name for wound edges opening up, dehiscence. Okay, so wounds that are healed by secondary intention, remember the hole that we dug and we had to close it, it will only gain a maximum of 80% of the original tensile strength after 1 year. So that's why it's very important, even after the wound has healed and it's in the maturation phase, to make sure that nothing causes breakdown of that scar. With incision, it's only 70% of the original. With secondary intention wound healing, maximum of 80% of the tensile strength after 1 year. All right, so then later on during maturation, the scar becomes lighter in color. It's not red and raised, but it becomes lighter and it becomes flatter and less prominent, lighter pink and lighter grayish silverish in color. And this maturation phase can last up to a year.